to psychological disorders and disorders of anxiety and obsessions. 14. Introduction to psychological disorders and disorders of anxiety and obsessions. 15. What is a psychological disorder? Unit 1. What is a psychological disorder? 1.0 Introduction. Psychological disorders are fairly common. This should not surprise you. When we speak about health, it encompasses both physical and mental health. However, invariably, our attention is drawn primarily towards physical problems and diseases. Psychological disorders or psychopathology have certain symptoms, etiology, how it occurs, the conditions in which it is maintained, and effect on day-to-day functioning of the individual. Psychological disorder may develop in anyone, irrespective of age, gender, ethnicity, region, and other such factors. It affects the people surrounding the person who has a psychological disorder. At times, people experience more than one disorder at the same time, comorbidity. Psychological problems are on the rise not only in India, but across the world. Observing the frequency and widespread suffering that the disorder causes, it becomes pertinent to understand its nature. To start with this, in the present unit, history, classification, and criteria of psychological disorders will be discussed, followed by the causal factors and assessment of psychological disorders. 1.1 What is a psychological disorder? According to Barlow and Durand, 2008, psychological disorder is a psychological dysfunction within an individual that is associated with distress or impairment in functioning and a response that is not typical or culturally expected. Let us examine the three criteria enlisted in this definition of a psychological disorder. Psychological dysfunction in the definition refers to breakdown in cognitive, emotional, or behavioral functioning. For example, you are out in a market for shopping, but instead of enjoying it, you experience severe fear all the time and just want to rush back home, even though there is nothing to be afraid of, and this happens every time when you go to the market. However, if there was a bomb scare or a riot erupted in that market in the recent past, then it would not be dysfunctional for you to be fearful and avoid that market for some time. Many people may experience a mild version of a fearful reaction without meeting the criteria for a disorder. To draw the line between normal and abnormal dysfunction is often difficult. Hence, these problems are often considered to be on a continuum or a dimension, rather than as categories that are either present or absent. Thus, having a dysfunction is not enough to meet the criteria for a psychological disorder. Distress or impairment in functioning seems to be an important and clearly defined component. However, it is often quite normal to be distressed, e.g., death of a loved one. There are certain disorders which do not lead to personal distress, e.g., mania, in which the patient feels elated and enjoys it so much that she avoids treatment but nonetheless is still in a dysfunctional state. The concept of impairment is useful though not entirely satisfactory, e.g., a person may consider herself shy, but it does not mean she is abnormal unless they are unable to interact with people and make friends. This again illustrates that most psychological disorders are extreme expressions of normal emotions, behaviors, and/or cognitive processes. Atypical or not culturally expected is an important but insufficient criterion to determine abnormality. At times, things are considered abnormal because they occur infrequently and deviates from the average. The greater the deviation, the more abnormal it is. However, not all kinds of deviation can be considered as disorders, e.g., artists usually deviate from normal, but instead of being identified as disordered, they are called talented and with unusual thinking. Not only such people are well paid, but they enjoy their careers as well. The society accepts such unusual thinking. In addition to the above, some other criteria are: violation of social norms is considered to be abnormal. This definition is very useful in understanding the cultural differences in psychological disorders, e.g., to enter a trance state or to believe that one is possessed, reflects a psychological disorder in Western cultures but not in many other cultures where it is expected and accepted. Sapolsky, 2002. However, violation of social norms as a criterion has been misused, e.g., political dissidents are often committed to mental institutions, for example, during dictatorship in former Soviet Union. 17. What is a psychological disorder? Statistical infrequency as defined by Davison, Neal and Kring, 2004, is a criterion for abnormal behavior. The normal curve places most people in the middle as far as any characteristic is concerned, and very few people fall at either extreme. Statistical infrequency is used explicitly in diagnosing intellectual disabilities. Wakefield, 1992-1999, proposed abnormal behavior as a harmful dysfunction. This definition has two parts: harmful and dysfunction. Harmful is a value judgment, whereas dysfunction is an objective, scientific component. To judge a behavior as harmful requires some standard which is likely to depend on socio-cultural values. Dysfunction occurs when an internal mechanism is unable to perform the function for which it was designed by evolution. The problem with Wakefield's definition is that while in medicine, dysfunctions can be identified in a rather straightforward manner, e.g., clogged arteries cause cardiovascular disease. However, in case of mental disorders, mental or biological mechanisms that are not functioning properly are largely unknown, e.g., schizophrenia is caused due to excessive secretion of dopamine or lack of postsynaptic receptors is still being investigated. Thus, no single criterion provides a satisfactory definition of abnormal behavior. However, together the criteria provided a framework initially to define abnormality. Variants of these approaches are most often used in current diagnostic practice and is outlined in DSM-5, American Psychiatric Association, 2013. DSM-5 defines psychological disorder as the behavioral, emotional, or cognitive dysfunctions that are unexpected in their cultural context and associated with personal distress or substantial impairment in functioning. 2. History of psychological disorders. In this section, we highlight some views on psychological disorders from a historical perspective. Ancient views of psychological disorders. Over the centuries, human efforts to explain abnormal behavior have ranged from demonology, magic, theology, physiology to psychology. The earliest evidence that attempts to understand abnormal behavior comes from Egyptian papyri, 16th century BCE, Oshaka and Oshaka, 2000, which shows that the brain was recognized as the site of mental functions. Diseases with unknown. 18. Introduction to psychological disorders and disorders of anxiety and obsessions. Causes were treated with incantations and magic. In ancient civilizations of China, Greece, and Egypt, abnormal behavior was attributed to possession by God or demons depending on the symptoms. If the behavior was religious, the person was thought to be possessed by God. But if the behavior was aggressive, bizarre, or overexcited, then the person was thought to be possessed by demons. The possessed individuals were treated through exorcism, driving out an evil spirit from a person or a place. Later in Greece, medical perspective was used to understand mental disorders and their treatment under the leadership of Pericles, 461 to 429 BCE. This period also saw the rise of father of modern medicine Hippocrates, the Greek physician, who rejected demonology and instead suggested that just like physical illnesses, mental illnesses are also caused by natural processes such as brain pathology and require appropriate treatment. He saw brain as the central organ of intellectual activity, identified the role of heredity and head injuries as a cause of mental and sensory disorders. He also gave the famous classification of mental disorders into 3 categories: mania, melancholia, and phrenitis, brain fever. He classified personalities based on 4 humors: blood, phlegm, black and yellow bile, in the human beings, Marr and Marr, 1994. Plato. The Greek philosopher Plato, 429 to 347 BCE, took a philosophical view of mentally disturbed individuals and suggested that they are not responsible for the criminal acts committed by them and hence should not be given punishment like the common people. He suggested that mentally disturbed individuals should be kept in hospitals run by society. His famous book, The Republic, underscores the importance of individual differences in mental and physical abilities and role of socio-cultural factors in thinking and behavior. Though Plato had a modern outlook, he believed that mental disorders are also partly caused by divine factors. Aristotle, 384 to 322 BCE, who was a disciple of Plato, has written extensively about mental disorders and consciousness. He rejected the psychological factors like emotions and cognitions as causes of mental disorders and accepted Hippocrates' biological views on mental disorders. Hippocrates' work was supported by some of the later Greek and Roman physicians such as the most. 19. What is a psychological disorder? Influential Greek physician, Galen, 130 to 200 CE. He did anatomical studies of the nervous system in animals. Human autopsies were not allowed till then. He also divided the causes of psychological disorders into physical and mental categories. China was one of the earliest developed civilizations to provide medical attention to mental disorders. Sung, 2006. Chinese medicine took a natural then a supernatural view of mental disorders. It was based on the premise that mental disorders occur because of disbalance of yin and yang, positive and negative forces, and treatment involved restoring the balance between yin and yang. Sang, 1973. Ancient Indian texts give description about mental disorders. In Ayurveda, science of life, personality types and temperament depend on the humor, systemic and mental perspectives. There are 3 humors: vata, ether; pitta, bile; and kapha, phlegm. Based on this classification, there are 7 personality subtypes. There are 5 other basic elemental subtypes and 8 systemic subtypes of personality that are the basis of all physical and mental disorders. Dwivedi, 2002. Atharveda classifies mental disorders of both mild and severe in nature. Sharaka Samhita and Sushruta Samhita also give a detailed description about diseases that include mental disorders. Psychological disorders in the Middle Ages. During the Middle Ages, about 500 to 1500 CE, when Europe was immersed in darkness and the scientific knowledge developed by Greek philosophers was pushed into oblivion, Islamic countries of West Asia protected Greek medicine and furthered its research and knowledge. In Persia, Avicenna, 980-1037 CE, referred as the Prince of Physicians, wrote the most widely referred work in the world titled The Canon of Medicine. In Baghdad in 792 CE, the first mental hospital was established. In contrast to this progressive attitude, Europe was devoid of scientific inquiry and humane treatment for the mentally ill people. Supernatural explanations were given for abnormal behavior, and mentally ill were often accused of being possessed by devil, witchcraft, and met with violent deaths such as burnt at stake, drowned or beheaded. In 1486 CE, Pope Innocent published a witch-hunting handbook, Malleus Maleficarum, Witch's Hammer, which describes ways of actively hunting out the suspected witches and punishing them. 20. Introduction to Psychological Disorders and Disorders of Anxiety and Obsessions. By the end of the Middle Ages and with the advent of Renaissance, society began taking a humane view of mental disorders. Swiss and German physicians, Paracelsus, 1490 to 1541 CE, and Johann Weyer, 1515 to 1588 CE, respectively, criticized superstitious beliefs about mental disorders. Weyer in 1583 also wrote a book, On the Deceits of the Demons, which describes step-by-step rebuttal of to Malleus Maleficarum. Weyer is considered as the founder of modern psychopathology, as he was the first specialist of mental disorders. Though he faced protests from church and his works were banned until the 20th century. The clergy themselves, for example, Saint Vincent de Paul, 1576 to 1660 CE, began questioning the prevalent inhuman practices for treating mentally ill. Strong advocacy for scientific view of mental disorders led to the development of modern clinical and experimental approaches. In 16th century, special institutions for mentally ill, known as asylums, were built, but these did not serve the purpose, and soon these places were reduced to being referred as madhouses. For example, St. Mary of Bethlehem was soon named as St. Mary of Bedlam. Asylums were also established in other countries like Austria, France, Mexico, Russia and USA, but all of these were in a pathetic state and needed reforms. Humanitarian treatment of people with psychological disorders and mental hygiene movement in France, Philippe Pinel, 1745 to 1826 CE, began the humanitarian treatment of mentally ill patients. At the same time, Tuke, 1732 to 1822 CE, in England also established a retreat in York for mentally ill and provided them with humane treatment. During this period, Benjamin Rush, 1745 to 1813 CE, in Pennsylvania, USA advocated moral management of patients with mental disorders. He is known as the founder of the American psychiatry. He wrote the first systematic treatise on psychiatry in America, Medical Inquiries and Observations upon Diseases of the Mind, 1812, and was the first American to organize a course in psychiatry, Gentile and Miller, 2009. In the early 19th century, humanitarian treatment was replaced by mental hygiene movement by Dorothea Dix, 1802 to 1887 CE, in USA. She fought for the cause of poor and forgotten people in mental hospitals and jails. With her efforts, legislation was passed about state providing the mental hospitals, other facilities and financial aid for the treatment of mentally ill people. Fig. Contemporary views about psychological disorders. After the mental hygiene movement gained momentum in USA, technical advances occurred in USA and in Europe that gave rise to contemporary views of the mental disorders, its causes and treatment in the late 19th century. These views spanned over the biological, psychological and experimental arenas of inquiry. The biological field established the causation between brain pathology and mental disorders. For example, Emil Kraepelin, 1856 to 1926 CE, developed the biological viewpoint by emphasizing the importance of brain pathology and mental disorders. He also gave the classification system that became the precursor of modern-day classification system like Diagnostic and Statistical Manual, DSM. Sigmund Freud, 1856 to 1939 CE, introduced the psychological factors by developing a theory of psychopathology that established a causal relationship between mental disorders and inner psychological forces, like psychic energy, unconscious motives, and psychosexual stages of development. Theories of psychopathology were also developed through the experimental studies. The first lab of psychology was established in Leipzig, Germany in 1879 by Wilhelm Wundt, who showed that psychological processes can be studied through experimentation. Soon it was followed by Cattell, 1860 to 1944 CE, who studied individual differences in mental processing by adopting Wundtian methods. Other important works in the tradition of experimental psychology were also carried out that provided a new direction to the theory of psychopathology. For example, Ivan Pavlov, 1849 to 1936 CE, gave the principles of classical conditioning based on his famous experiments with the dogs. John B. Watson, 1878 to 1958 CE, through his experiments, Little Albert, established that all behavior, adaptive and maladaptive, is learned, and so unlearning of the maladaptive behavior can be used as an effective treatment. Thus, understanding the history of psychopathology helps us to appreciate the struggles and efforts of various thinkers and researchers in the emergence of abnormal psychology, and that makes us to understand and treat mental disorders in an efficient, scientific, and humane way. 1.3 Psychological models. There are various approaches to explain mental health disorders and problems. It is not only the individual's biological makeup but also psychological factors, like childhood experiences, learning, thinking, how one processes information, and such other related factors that influence the development and maintenance of psychological disorders. Thus, in this section the main psychological models, namely, the psychodynamic model, the behavioral model, the cognitive model, humanistic existential model and socio-cultural model, will be discussed. 1. The psychodynamic model. The psychodynamic approach was posited by Austrian neurologist Sigmund Freud. In his theory of psychoanalysis, first of the talking therapies, attempted to explain normal and abnormal behavior. Activities during childhood are driven by satisfying the needs of id. How does one's psychological mechanisms cope with anxiety and the way in which memories are repressed that might cause conflict and stress, are important in explaining normal and abnormal functioning. Psychological health is maintained when there is a balance among id, ego and superego. If these are in conflict, it will result in psychopathology. Conflict is reduced by using defense mechanisms. 2. The behavioral model. The model is based on behavioristic school of psychology. The model puts forth that psychopathology is the result of learned reactions to environmental experiences. Faulty learning is the result of either classical conditioning or operant conditioning. 3. The cognitive model. The approach was first introduced by Albert Ellis, 1962, and Aaron Beck, 1967. The model proposes psychopathology to be the result of individual acquiring irrational beliefs, developing dysfunctional ways of thinking and processing information in biased ways. 4. The Humanistic Existentialist model. The model proposes that insight into behavioral and emotional problems. People acquire psychological conflicts, however, they have the ability to acquire self-awareness, values, sense of meaning of life and pursue freedom of choice. 5. Socio-Cultural Model. Social and cultural factors play an important in the development and course of mental disorders. Individual's culture and group. 23. What is a psychological disorder? Value system play an important role. Daily life stressors may increase the vulnerability for mental disorders. However, studies also conclude that factors like ethnic identity can buffer against the stressors and protect mental health. Mosikowski, 2003. 1.4 Classification of psychological disorders. In our daily lives, we come across a lot of information in the form of objects, elements, concepts, living beings, etc. It is amazing that we can deal with so much information. We do so by putting information into classes or categories based on our observations of shared characteristics. For example, all four-legged creatures are categorized as animals. Classification can be defined as making generalizations based on our observations. Classification is a necessary step for making sense of information in all formal fields of knowledge, such as sciences, literature, etc. Just like other fields of knowledge, abnormal psychology also makes use of classification to deal with information about the various disorders, their causes and treatments. Carson, Butcher, and Manica, 2007, have defined classification in abnormal psychology as an attempt to delineate meaningful sub-varieties of maladaptive behavior. While diagnosis is assigning an individual to a category of a disorder, e.g., phobia, depression, etc., based on symptoms, classification is assigning all the possible categories to a system that will form the basis for diagnosis. Need for classification in abnormal psychology, Carson, Butcher, and Manica, 2007. It differentiates among various types or categories of maladaptive behavior. It brings order to the nature, causes, and treatment of such behavior. It helps in meaningful communication about behavior, normal and abnormal. It provides the basis for epidemiological data such as incidence and prevalence of various disorders. It provides the basis for formal diagnosis, which is especially required by the socio-legal system, e.g., insurance claims, court of law. It also helps in identification of new type of disorders which require new treatment techniques. Approaches of classification: 1. Classical categorical, 2. Dimensional, and 3. Prototypical. 1. Classical categorical approach originated in the work of Emil Kraepelin, 1856 to 1926 CE, and the biological tradition in the study of psychopathology. According to Butcher, Manica, Hooley, and Dwivedi, 2016, classical approach assumes the following. A. All human behavior can be divided into the categories of healthy and disordered. B. Disorders are divided into discrete and non-overlapping classes. C. Only one set of causal factors per disorder exist. 24. Introduction to psychological disorders and disorders of anxiety and obsessions. D. There is only one set of defining criteria for each disorder, which must be met for making a formal diagnosis. Criticism. Psychological disorders are complex because psychological and social factors interact with the biological factors to produce a disorder. The mental health field, thus, did not adopt classical categorical model, Francis and Weidegger, 1986. 2. Dimensional approach as opposed to the classical categorical approach assumes that a person's behavior is defined in terms of different strengths along several dimensions, for example, emotional stability, mood, aggression, etc., which can be rated on a Likert type of scale. Thus, a person's behavior can be defined on a scale of 0 to 10, as mildly anxious, 2, moderately depressed, 5, or mildly aggressive, 2. B. Same dimensions are to be used for defining behavior of everyone. C. Difference in behavior would be based on the ratings on the established dimensions that may range from low to high. Criticism. Theorists have not reached a consensus on the number of dimensions that can be used to define human behavior, as some agree on one dimension while others identify more than 33 dimensions. Millen, 1991. 3. Prototypical approach combines both categorical and dimensional approaches. A prototype is a conceptual entity depicting an idealized combination of characteristics that more or less regularly occur together in a less than perfect or standard way at the level of actual observation. Butcher, Manika, Hooley, and Dwivedi, 2016. According to this approach, certain essential characteristics are required to classify an entity. However, there are some non-essential characteristics also that do not change the classification. Criticism. The categories of disorders are not clearly defined, as some symptoms are shared by more than disorder. However, it has become the most favored approach as it is user-friendly and enlists many different features of the disorder, out of which not all but some are required for the formal diagnosis. How did we reach to the present system of classification? Crane, Johnson, Davison, and Neal, 2012, have enlisted the following efforts in classification. 1882, UK. Statistical Committee of the Royal Medico-Psychological Association produced a classification system, revised several times but was never adopted by its members. 1886, USA, Association of Medical Superintendents of American Institutions for the Insane, a forerunner of American Psychiatric Association, APA, adopted a revised British system. 1889, Paris, Congress of Mental Science adopted a single classification but was never widely used. 1913, USA, APA accepted a new classification and incorporated some of Kraepelin's ideas, but it lacked in consistency. 25. What is a psychological disorder? Development of ICD, World Health Organization, and DSM, American Psychiatric Association, Systems 1939, WHO. Added mental disorders to the International List of Causes of Death, ICD, 1948, WHO. International Statistical Classification of Diseases, Injuries, and Causes of Death included Classification of Abnormal Behavior, published the 6th version, ICD 6 1952, APA. Diagnostic and Statistical Manual of Mental Disorders, DSM, 1968, APA. DSM-2, reliability was very low 1969, WHO. A new classification system 1980, APA. DSM-3 1987, APA. DSM-3R, R stands for revision, 1990, WHO. ICD-10 was endorsed 1994, APA. DSM-IV 2000, APA. DSM-IV-TR, TR stands for text revision, 2013, APA. DSM-5 2018, WHO. A version of ICD-11 was released. General criticisms of Classification 1. Classification leads to loss of information. Classifying a person as depressed or anxious results in loss of information about that person, reducing his/her uniqueness. However, it is important to know whether the information lost is relevant. Kring et al., 2012. 2. Labeling. Once labeled, an individual starts identifying him/herself with the negative connotations associated with the label. It also leads to stigma, as mental disorders are viewed negatively by the society. Wall and Herman, 1989. Kring et al., 2012, draw attention to some specific criticisms of diagnosis by DSM. They are as follows. Discrete entity versus continuum, categorical versus dimensional classification. The debate of discrete versus continuum has not been resolved, and despite criticism of categorical approach, DSM represents a categorical that is a yes-no approach to classification. Reliability. The extent to which a classification system or a test produces the same scientific observation each time it is applied. Reliability of DSM-I-2 was not accepted. Though, later DSMs improved on the account of reliability, however, it still remains questionable. Validity. The extent to which a classification system measures what it is supposed to measure. The diagnoses of DSM are referred to as constructs because they are inferred, not proven, entities. Construct validity is determined by evaluating the extent to which accurate statements and predictions can be made about a category once it has been formed. So, DSM describes the constructs and not facts. 26. Introduction to psychological disorders and disorders of anxiety and obsessions. Nevertheless, classification systems like DSM help us in understanding the various disorders, differences among them, their causes, and to plan treatment. According to Barlow and Durand, 2005, DSM-3 in 1980 was a landmark in the history of nosology, classification, as it departed radically from its predecessors, and three changes stood out. First, a theoretical approach to diagnosis was attempted that used the precise description of the disorder rather than theories of causal factors. Second, specific and detailed criteria for disorders helped to study their reliability and validity. Third, it introduced a multi-axial system that allowed clinicians to have a detailed information about their patients through rating them on 5 different dimensions, or axes. The details of multi-axial system are given below. Axis I. The disorder itself, such as schizophrenia or mood disorder, axis II. More enduring, chronic disorders of personality, axis III. Physical disorders and conditions, axis IV. Amount of psychosocial stress reported by the patient and rated by the clinician in a dimensional fashion, axis V. Current level of adaptive functioning. A revision of DSM-3 called DSM-3R was published in 1987, with further improvement in reliability and validity. Problems with DSM-3 and 3R. Some of the diagnostic categories had low reliability. Some criteria were whimsically rather than empirically established, e.g., one of the criteria for panic was 4 panic attacks in a 4-week period. A figure reached through an approximation rather than research. Despite shortcomings, DSM-3 and 3R had a substantial impact. It was more popular and more clinicians used it than the ICD system. ICD-10 was published in 1993, and to increase compatibility between DSM and ICD-10, work on DSM-IV and ICD-10 was started simultaneously. DSM-IV, 1994, and DSM-IV-TR, 2000, according to Barlow and Durand, 2005. Scientific data was used to make changes in the diagnostic system. Reanalysis of large set of data was done to increase its utility for DSM-IV. Independent field trials examined the reliability and validity of alternative sets of definitions or criteria, and, in some cases, the possibility of creating a new diagnosis. Weidegger et al. 1998. The distinction between organically and psychologically based disorders was eliminated. The multi-axial system remains with some changes in the 5 axes. These changes were as follows. Axis I. Pervasive developmental disorders, PDD, learning disorders, LD, motor skills disorders, and communication disorders, previously coded on axis II are now coded on axis I. 27. What is a psychological disorder? Axis II. Personality disorders and mental retardation, axis III. General medical conditions, axis IV. Psychosocial and environmental problems, instead of. Psychosocial stress in DSM-3 and 3R, axis V. Current level of functioning using the GAF, Global Assessment of Functioning, rating scale of 0 to 100, in life areas, social and occupational relationships and use of leisure time. Importance of multi-axial system. Usually people consult a clinician for axis I disorder. Axis II disorder may exist prior to axis I disorder. Presence of axis II along with axis I condition indicates difficulty in treatment. Axes III, IV, and V indicate the factors other than the symptoms that should be considered in an assessment to understand the overall life situation, i.e., axis III indicates medical condition believed to be relevant to the present. Disorder. Axis IV indicates a proximal and a contributory cause. Axis V indicates how much the person needs treatment based on GAF. Ratings. Other positive points of DSM-IV and DSM-IV-TR. Extensive description of diagnostic categories. For each disorder there is a description of essential features, associated features, lab findings and physical examinations, research literature about age of onset, course, prevalence and sex ratio, familial pattern, and differential diagnosis. Social and cultural considerations. Cultural Formulation Guidelines is a plan for integrating important social and cultural influences on diagnosis, Mezich et al. 1999, e.g., what is the primary social and cultural group of a patient, e.g., Chinese, Hispanic, etc.? Have the immigrants mastered the language of their new country? Does the patient use term and descriptions from his or her old country to describe the disorder? These cultural considerations must not be overlooked in making diagnosis and planning treatment, but yet, there is no research supporting the utility of these cultural formulation guidelines, Alarcon et al. 2002. Overall, the reliability of DSM has improved due to increased explicitness of the DSM criteria. Use of standardized, reliably scored interviews for collecting the information needed for a diagnosis. According to Davison, Neal, and Kring, 2004, following problems remained in DSM-IV and DSM-IV-TR. Discrete entity versus continuum issue remains unresolved. Arbitrariness in the rules for making diagnosis, e.g., diagnosis of mania is given if the person shows at least 3 out of 7 symptoms listed, or 4 if their mood is irritable, but why require 3 and not 2 or 5 symptoms? 28. Introduction to Psychological Disorders and Disorders of Anxiety and Obsessions. The reliability of axes I and II may not always be high in daily usage, for clinicians may not adhere as precisely to the criteria as the researches. The increased reliability may improve validity, but it is not guaranteed. A diagnosis may not reveal anything useful about a patient. Subjective factors may still play a role in evaluations as well as cultural factors may creep in. Not all the DSM classification changes seem positive, e.g., should a problem in learning or arithmetic, or reading be considered a psychiatric disorder? Many childhood problems are made into psychiatric disorder, without good justification for doing so, thereby causing a risk of labeling a child with a disorder. Continued efforts to improve DSM has led to DSM-5. The DSM-5 was published in 2013 after much debate and controversy. The key aspects are as follows. Multi-axial system has been abandoned in DSM-5. It has used an operational approach to diagnosis, for example, diagnostic criteria for persistent depressive disorder, dysthymia, are based on a combination of diagnostic criteria from 2 diagnoses from DSM-IV, chronic major depression and dysthymic disorder. It has become more comprehensive and differentiated through addition of newly diagnosed disorders as well as by dividing the previous disorders into subcategories. Gender differences have been accounted for diagnosis by providing the differences in prevalence rates and symptoms between male and female patients. For example, antisocial disorder, prevalence is higher in males, and anorexia, higher prevalence in females, and symptoms of conduct disorder are different in males and females, Butcher et al., 2016. Appraisal of cultural background has also been done as nowadays clinicians have to diagnose and treat many patients who come from cultural backgrounds that are different from that of the client. Further, migrants are likely to perform more poorly on diagnostic tests not because of a psychological problem but because of unfamiliar language and its nuances being used in the country to which they have migrated. Additionally, their anxiety, depression or other disorders show more severe manifestations because of the stress due to socio-cultural factors. Okazaki, and Su, 2009. Hence, the clinician must consider the client's background, attitudes and social values while taking their case history and subsequent therapy sessions. The DSM-5 contains a structured interview which has a 16-item cultural formulation interview, CFI. The interview inquires about the patient's perspectives on their present problems, how they perceive the influence of others in influencing their problems, ways in which their cultural background can influence their adjustment and their experiences in seeking treatment for their problems. Despite several improvements have been made in DSM-5, however, it continues to suffer from the problem of labeling. Thus, when an individual 29. What is a psychological disorder? Is labeled as suffering from schizophrenia, for example, The label does not provide any information about the patient as an individual, her strengths and weaknesses other than disorder and the disorder itself. The individual who is labeled also takes the role of the patient and expects herself to behave in a certain way which is expected from a psychotic patient. Thus, labeling has a negative effect on the patient as once labeled. The label sticks to the patient for life and her other qualities are ignored. Nevertheless, diagnosis is required to understand the causes and prognosis of a disorder, as well as to decide its treatment. Hence, DSM-5 does play an important role in diagnosis, but practitioners must use it with caution to avoid labeling of a person at the cost of her personhood. Check your progress 3.1. What are the main psychological models that try to explain mental psychological disorders? In this section, we discuss the main causes of psychological disorders. What causes abnormal behavior? So far, the field of abnormal psychology has been unable to provide a single direct answer to this question. Hence, many investigators prefer to talk in terms of risk factors, variables correlated with an abnormal behavior, rather than causes. Butcher, Hooley, Manica, and Dwivedi, 2017. Nevertheless, understanding the causes remains the ultimate goal. Causal factors can be analyzed by considering the following. 30. Introduction to psychological disorders and disorders of anxiety and obsessions. Distinction between necessary, sufficient, and contributory causes. The problem of feedback and circularity in abnormal behavior. Concept of Diathesis stress model of abnormal behavior. The above are explained as follows. Necessary, sufficient, and contributory causes. Necessary cause. A condition that must exist for a disorder to occur. It is not always sufficient by itself to cause a disorder. Many mental disorders do not seem to have a necessary cause, and the search for such causes continues. Sufficient cause. A condition that guarantees the occurrence of a disorder. A sufficient cause may not be a necessary cause. For example, hopelessness is a sufficient cause of depression, but it is not a necessary cause, as there are other causes of depression as well. Abramson, Alloy, and Medelsky, 1995. Contributory cause. A condition that increases the probability of developing a disorder but is neither necessary nor sufficient for the disorder to occur, e.g., divorce might precipitate depression. Time frame under which different causes operate is also important. Butcher et al. 2017. Distal causal factors. Causal factors that occur early in life and may not show their effect for many years, but may contribute to a predisposition to develop a disorder, e.g., death of a parent in early childhood may become a distal cause for depression in adulthood. Proximal causal factor. Causal factor that operates shortly before the occurrence of the symptoms of a disorder. It may be a condition that proves too much for a person and may trigger a disorder. Sometimes it may seem to be trivial and only distantly related to the more distal causes, proverbial for the straw that breaks the camel's back. For example, a minor argument between a couple may lead to major difficulties in case of a couple who are already experiencing marital problems. Reinforcing cause. Condition that tends to maintain maladaptive behavior that is already occurring, e.g., pampering by parents may lead to maintenance of illness in a child. For many forms of psychopathology, we do not yet have a clear understanding of whether there are necessary or sufficient causes. However, we do have a good understanding of many of the contributory causes for most mental disorders. Further, what may be a proximal cause at one stage in life may become a distal cause for a disorder later in life, e.g., loss of a parent in childhood may be a proximal cause for the child's grief reaction and may become a distal cause for an anxiety disorder later in adulthood. The problem of feedback and circularity in abnormal behavior. Abnormal behavior most often does not follow a simple linear model of cause and effect, and sometimes it becomes difficult to distinguish between cause and effect, e.g., whether excessive drinking in a spouse leads to rejection by the other partner or rejection by the partner leads to excessive drinking. 31. What is a psychological disorder? Diathesis stress model. The diathesis stress model is a psychological theory that explains behavior as both a result of biological and genetic factors, nature and life experiences, nurture. This model thus assumes that a disposition towards a certain disorder may result from a combination of one's genetics and early learning. Diathesis is the predisposition toward developing a disorder. It can derive from biological, psychosocial, and/or socio-cultural causal factors. Stress is the response of an individual to demands that she perceives as taxing or exceeding her personal resources. According to the model, this predisposition, in combination with certain kinds of environmental stress, results in abnormal behavior. Diathesis stress models have been proposed by Meehl, 1962, Medelsky et al., 1982, Rosenthal, 1963, Zuckerman, 1999. This theory is often used to describe the manifestation of mental disorders, like schizophrenia, that are produced by the interaction of a vulnerable hereditary predisposition with precipitating events in the environment. It was originally introduced as a means to explain some of the causes of schizophrenia. Vulnerability in the diathesis stress model, a biological or genetic vulnerability or predisposition. Diathesis interacts with the environment and life events, stressors, to trigger behaviors or psychological disorders. The greater the underlying vulnerability, the less stress is needed to trigger the behavior or disorder. Conversely, where there is a smaller genetic contribution, greater life stress is required to produce the particular result. Nevertheless, it is a distal necessary or contributory cause, and is not sufficient to cause a disorder, i.e., someone with a diathesis towards a disorder does not necessarily mean they will ever develop the disorder. Both the diathesis and the stress are required for this to happen. Assessment of psychological disorders. Psychological assessment dates to Galton's work, 1879, and is one of the oldest and most widely developed branches of contemporary psychology. Butcher, 2010. 32. Introduction to Psychological Disorders and Disorders of Anxiety and Obsessions. Wiener and Green, 2008. Butcher, Hooley, and Manica, 2014, have defined psychological assessment as: psychological assessment refers to a procedure by which clinicians, using psychological tests, observation, and interviews, develop a summary of the client's symptoms and problems. Clinical diagnosis is the process through which a clinician arrives at a general, summary classification of the patient's symptoms by following a clearly defined system such as DSM-5 or ICD-10, International Classification of Diseases, the latter published by the World Health Organization. Clinical assessment may be defined as the collection, organization, and interpretation of information about a person and his or her situation. Boutsen, 1997. According to Butcher et al., 2014, psychological assessment can be an ongoing process that proceeds along with, rather than only preceding, treatment efforts, and may be important during treatment, e.g., to assess outcome. Pre-treatment assessment has several functions, such as, it helps in establishing baselines for various psychological functions so that the effects produced by treatment can be measured. It can be used in court testimony. It helps in screening candidates for various roles and occupations, and usually the effort is to identify people who seem to be unfit for a certain occupation. The basic elements in assessment are as follows. 1. Diagnosis. Presenting problem must be adequately classified for several reasons. Medico-legal cases may require it, helps in planning and managing the treatment, helps the administration to provide the facilities needed. Taking a social history, that means a basic understanding of the individual's history, intellectual functioning, personality characteristics, environmental pressures, and resources, helps in understanding the disorder that has brought the person to the clinic. 2. Personality factors, such as long-term personality characteristics. 3. The social context. The environmental demands, the supports, and the social stressors that exist in a person's life. The integration of the above information leads to a dynamic formulation which describes the current situation and includes hypotheses about what is driving the person to behave in maladaptive ways. Butcher et al., 2014. Carson, Manica, Butcher, and Hooley, 2013, have enlisted the following factors that influence the assessment process. Clinician's professional orientation, e.g., a psychiatrist will likely focus on biological assessment methods, trust and rapport between the clinician and the client. Reliability and validity in assessment. Reliability refers to consistency of measurement. Following are the types of reliability. 33. What is a psychological disorder? Test-retest. The extent to which people being observed or tested twice score in the same way. Alternate or parallel form. The extent to which scores on the two forms of the test are consistent. Inter-rater. The degree to which two independent observers or judges agree. Internal consistency. The extent to which items of a test are related to each other. Validity refers to whether the measure fulfills its intended purpose. Following are the types of validity. Content validity. Whether a measure adequately samples the domain of interest. Criterion validity. Whether a measure is associated in an expected way with some other measure. Criterion. It can be assessed by evaluating the ability of the measure to predict some other variable in future, e.g., IQ tests are used as predictors of later school achievement. Concurrent validity. The extent to which a relationship exists between two variables that are being measured at the same time, e.g., on a measure of distorted thoughts, depressed people score higher than the non-depressed people. Construct validity. Whether a test is a measure of a characteristic or construct. Cronbach and Meal, 1955. A construct is an inferred attribute, such as anxiousness or distorted cognition. 1.7 Types of assessment. Clinical psychologists collect the data and evaluates the information from the individual with regard to psychological disorder, to make diagnosis, plan the treatment, and prognosis, predict the outcome. The following are the main types of assessment for psychological disorders. A biological assessment. B. Psychological assessment. Interview. Clinical interview. Psychological tests observing behavior. C. Behavioral and cognitive assessment. A biological assessment. Biological assessment includes 1. Brain imagery. Seeing the brain and how its structure and functioning may be related to abnormal behavior. The following techniques are used for brain imaging. A. Computerized axial tomography scan, CT or CAT. This helps to assess structural brain abnormalities. A moving beam of X-rays passes into a horizontal cross-section of the patient's brain, scanning it through 360 degrees. The moving X-ray detector on the 34. Introduction to psychological disorders and disorders of anxiety and obsessions. Other side measures the amount of radioactivity that penetrates and detects subtle differences in tissue density. A computer uses the information to construct a two-dimensional, detailed image of the cross-section, giving it optimal contrasts. Then the patient's head is moved and the machine scans another cross-section of the brain. This way any structural abnormality, e.g., blood clots, tumors etc. can be detected. B. Magnetic resonance imaging, MRI, superior to CT scan. MRI produces pictures of higher quality and does not rely on even the small amount of radiation required by a CT scan. In MRI, the person is placed inside a large, circular magnet, which causes the hydrogen atoms in the body to move. The magnetic force is turned off, the atoms return to their original position and produce an electromagnetic signal. These signals are read by the computer and translated into pictures of brain tissue. It has allowed brain surgeries of such delicate parts of the brain which otherwise would have been inoperable without clear pictures. C. Functional MRI or fMRI. It allows to take pictures of brain at work. fMRI studies have found less activation in the frontal lobes of patients with schizophrenia than in the frontal lobes of normal people as they performed a cognitive task, e.g., Yergel and Todd et al., 1996. D. Positron emission tomography, PET. This is an expensive and invasive procedure that allows measurement of both brain structure and function. A substance used by the brain is labeled with a short-lived radioactive isotope and injected into the bloodstream. The radioactive molecules of the substance emit a particle called a positron, which quickly collides with an electron. A high-energy light particle shoots out from the skull in opposite directions and are detected by the scanner. The computer analyzes millions of such recordings and converts them into a picture of the functioning brain. The images are in color. Fuzzy spots of lighter and warmer colors are areas in which metabolic rates for the substance are higher. Visual images of the working brain can indicate sites of epileptic seizures, brain cancers, strokes etc., as well as the distribution of psychoactive drugs in the brain. 2. Neurochemical assessment. PET scanning allows an assessment of receptors for a given neurotransmitter. In postmortem studies, the brains of deceased patients are removed and the amount of specific neurotransmitter and receptors in brain areas can then be directly measured. By analyzing the metabolites of neurotransmitters that have been broken down by enzymes. Metabolite is typically an acid, which is produced when a neurotransmitter is deactivated, e.g., homovinylic acid is the metabolite of dopamine, 5-hydroxyandoleacetic acid is the metabolite of serotonin. Metabolites can be detected in urine, blood, and cerebrospinal fluid. A high level of a particular metabolite indicates a high level of a neurotransmitter. 35. What is a psychological disorder? 3. Neuropsychological assessment. First, let us see the difference between a neurologist and neuropsychologist. A neurologist is a physician who specializes in medical diseases that affect the nervous system, e.g., cerebral palsy. A neuropsychologist is a psychologist who studies how dysfunctions of the brain affect the way we think, feel, and behave. They have developed tests called neuropsychological tests. These tests assess behavioral disturbances caused by brain dysfunctions. Such tests are often used in conjunction with brain scanning techniques. These are based on the idea that different psychological functions, e.g., motor, speed, memory, language, etc., are localized in different areas of the brain, e.g., Halstead-Rayton neuropsychological battery, developed by Halstead and then modified by Rayton and Davison, 1974, and Luria Nebraska neuropsychological battery, Golden, Hammock, and Purish, 1980. Halstead-Rayton battery includes the following tests. 1. Tactile performance test time, performing the form board test while blindfolded, first using the preferred hand and then the other, and finally both. It is sensitive to damage in the right parietal lobe. 2. Tactile performance test memory. After completing the timed test, patient is asked to draw the form board from memory, showing the blocks in their right location. 3. Speech sounds perception test. Participants listen to a series of nonsense words, each comprising 2 consonants with a long E sound in the middle. They then select the word they heard from a set of alternatives. It measures left hemisphere function, especially temporal and parietal areas. This battery can help in making diagnostic decisions, e.g., it helps to discriminate between dementia due to depression and dementia due to a degenerative brain disease, Reed and Reed, 1997. Luria Nebraska neuropsychological battery is based on the work of a Russian psychologist, Alexander Luria, 1902 to 1977. It has 269 items spread out in 11 sections. 1. Basic and complex motor skills, rhythm and pitch abilities, tactile and kinesthetic skills, verbal and spatial skills, receptive speech ability, expressive speech ability, writing, reading, arithmetic skills, memory, intellectual processes. 2. The pattern of scores is discriminating and indicative of overall impairment, helps reveal damage to the frontal, temporal, sensorimotor, or parietal occipital area of right or left hemisphere. 3. It takes 2.5 hours to administer it. Furthermore, it is believed to pick up effects of brain damage that are not yet detectable by neurological examination or imaging techniques. 36. Introduction to psychological disorders and disorders of anxiety and obsessions. 4. It can control for educational level so that a less educated person will not receive a lower score. Brickman et al., 1984. A version for children ages 8 to 12 for diagnosing brain damage and in evaluating the educational strengths and weaknesses of children. Golden, 1981. Sweet et al., 1986. 4. Psychophysiological assessment. Psychophysiology is a field of study that is concerned with the bodily changes that accompany psychological events or that are associated with a person's psychological characteristics. Grings and Dawson, 1978. Bodily changes include heart rate, muscle tensions, blood flow in various parts of the body, brainwaves, etc. The activities of the autonomic nervous system can be assessed by electrical and chemical measurements to understand the nature of emotion, e.g., heart rate is one important measure which is measured by electrocardiogram, ECG. Skin conductance or electrodermal responding, anxiety, fear, anger, etc. increase activities in the sympathetic nervous system, which then boosts sweat gland activity that in turn increases the electrical conductance of skin. Brain activity is measured by electroencephalogram, EEG, helps in detecting abnormal brain activity, e.g., epilepsy, brain lesions, etc. Portable devices are also being used to study blood pressure in vivo, as people go about their daily business. Critical evaluation of biological assessment. Many assessment techniques may not differentiate clearly among emotional states such as skin conductance, which not only increases in anxiety but in happiness also. Usually, there is no one-to-one relationship between assessment and psychological dysfunctions. Factors such as duration of brain damage, whether chronic or acute, coping strategies used by the patient, efforts at special education should be taken into account. A very important consideration is the abilities that the patient has brought to the event of brain injury, i.e., the patient's repertoire of abilities before the brain damage should be taken into account. B. Psychological assessment. Interviewing, psychological tests and observing behavior are the main methods to collect data about a psychological disorder. Interview. The purpose of the interview determines the type of interview to be conducted. The main types are as follows. Initial intake or admission interview. The purpose of the initial intake or admission interview is to understand the patient's symptoms and accordingly recommend the most appropriate treatment or intervention plan. The interview can be conducted when the patient is in hospital, inpatient care, outpatient facility, or any other mental health setting. Mental status examination. This is conducted primarily to screen the psychological functioning and mark out any absence or presence. 37. What is a psychological disorder? Of any abnormal mental phenomenon, such as delirium, hallucination, etc. Insight, judgment, attention, memory, thought processes, etc. are briefly evaluated. Crisis interview. Such an interview is conducted in the middle of a significant or a traumatic or life-threatening crisis. Professional engaged in suicide helplines or a mental health clinic often conduct crisis interview. Diagnostic interview. The purpose of diagnostic interview is to make a diagnosis after examining symptoms and problems. Diagnosis is formulated by the clinician based on DSM-5 classification. Unstructured interview. Clinicians operate from only the vaguest outlines. The information is collected largely depends on the interviewer and the responsiveness of the interviewee. Clinicians often rely on their intuition and general experience. As a consequence, reliability is probably low, i.e., two interviewers may well reach different conclusions about the same patient. Majority of clinical interviews are conducted within confidential relationships. Hence, it has not been possible to establish either their reliability or their validity through systematic research. Structured interview. Questions are set out in a prescribed fashion for the interviewer. Developed by mental health professionals in order to collect standardized information, particularly for making diagnostic judgments based on the DSM-5, e.g., Structured Clinical Interview for DSM-5 Disorders Clinical Version, Sci DSM-5 CV. It also contains detailed instructions to the interviewer concerning when and how to probe in detail and when to go on to questions about another diagnosis. Use of structured interviews such as SCID has led to improvement of diagnostic reliability. With adequate training, inter-rater reliability for structured interviews is generally good. Blanchard and Brown, 1998. Clinical interview. Korchin, 1986, has enlisted the following types of interviews. Clinical interview. Conversation between a clinician and a patient. It is aimed at determining history, causes for problems, and possible treatment options. Assessment-oriented interview. Typically occurs early in the patient's contact with the clinic. Its major purpose is to clarify the clinician's understanding of the patient's problems to plan further intervention. Therapeutic interview. Facilitates the patient's understanding of him, herself so as to effect desirable changes in his feelings and behavior. Characteristics of a clinical interview. Crane, Johnson, Davison, and Neal, 2012. Attention is paid to the way a respondent answers or does not answer questions. The paradigm within which an interview operates influences the type of information sought, how it is obtained, and how it is interpreted. It does not follow one prescribed course but varies with the paradigm adopted by the interviewer. 38. Introduction to psychological disorders and disorders of anxiety and obsessions. Establishing the rapport with the client and obtaining his/her trust is very important because interviews are usually carried out with people who are under considerable stress and sometimes are required to reveal personal information. Clinicians empathize with their clients in an effort to draw them out of their anxieties. A simple summary statements of what the client has been saying is helpful in sustaining the momentum of talk about painful and possibly embarrassing events. Accepting attitude toward personal disclosures dispels the fear that revealing secrets to another human being will have disastrous consequences. London, 1964. Situational factors of the interview may exert strong influence. However, clinicians often tend to overlook them. Psychological tests. Psychological tests are standardized sets of procedures or tasks for obtaining samples of behavior. Butcher et al. 2014. The clinician compares an individual's responses on a given test with the test norms or test score distributions and makes an evaluation about him/her based on those comparisons. Nowadays, along with the manual or paper pencil tests, their computer-administered and computer-interpreted formats are also available. In comparison to interviews and observational techniques, psychological tests are more precise and reliable. However, these are not perfect as the inferences drawn from such tests depend on competence of the clinician who administers and interprets the tests. Butcher et al. 2014. There are two main types of psychological tests, namely, intelligence and personality tests. Intelligence tests. A wide range of intelligence tests are available today, out of which the most widely used in the clinical practice to measure children intellectual abilities are the Wechsler Intelligence Scale for Children Revised, WISCIV, Weiss et al. 2006, and the Stanford-Binet Intelligence Scale, Camphouse and Cronk, 2004, Wasserman, 2003. Wechsler Adult Intelligence Scale Revised, WAIS-IV, is used to measure adult intelligence, Benson et al. 2010, Lichtenberger and Kaufman, 2009. It consists of 15 subtests and measures both verbal and nonverbal intelligence. These tests use extensive with exhaustive items to measure the intellectual abilities, however, are culturally biased. Also, it takes 2 to 3 hours to administer, score and interpret the individual's performance on these tests, hence, these are not time and cost effective. These tests are only used when it is absolutely necessary to measure an individual's intellectual abilities, for example, intellectual impairment, organic brain damage. Objective personality tests. These are the structured personality tests, such as questionnaires, self-report inventories, or rating scales with carefully phrased and precise items and alternative responses as choices. Butcher et al. 2017. The structured format allows objective quantification of the 39. What is a psychological disorder? Sample of behavior under study. The precision and quantification increase the reliability of such tests. Some of the widely used objective personality tests are the NEO-PI, Neuroticism Extroversion Openness Personality Inventory. Costa and Weidiger, 2002, used for normal population. The Millen Clinical Multiaxial Inventory, MCMI-3. C. Choka, 2004, used for clinical population. However, one of the most widely used personality assessment instrument is the Minnesota Multiphasic Personality Inventory Revised, MMPI-2, used for adults. Butcher, 2011. Green, 2011. Stark Hathaway and J.C. McKinley introduced MMPI for general use in 1943. It was revised in 1989 and renamed as MMPI-2 and remains till today the most widely used personality test for clinical and forensic court-related assessment and in psychopathology research in the United States. Archer et al. 2006. Lally, 2003. As well as the most frequently taught assessment tool in graduate clinical psychology programs, Piotrowski and Zaleski, 1993. The translated versions of the inventory are widely used internationally. The original MMPI was translated over 150 times and used in over 46 countries. Butcher, 2010. Over 32 translations of MMPI-2 have been made since its publication in 1989. Butcher and Williams, 2009. It is a self-report questionnaire, consists of 550 items which covers wide range of topics from physical condition and psychological states to moral and social attitudes. Though it is widely used as a diagnostic tool in clinical and forensic setups, however, it has been criticized by psychodynamic as well as behavior schools-oriented clinicians. While the psychodynamics-oriented clinicians criticized it for being too superficial and inadequate for measuring the complexities of human behavior, the behaviorally oriented clinicians felt it measured unobservable, mentalistic constructs such as traits. Butcher et al. 2014. Nevertheless, it remains one of the most exhaustive objective measure of personality. Overall, the objective personality tests have advantages as well as limitations. These are cost-effective, highly reliable, and objective and can be computer-administered and interpreted. However, these have been criticized for being too mechanistic and rely on the literacy ability of the patients. Moreover, since the items or questions are direct, so they may elicit not the true but socially desirable answers from the respondents. Projective personality tests. These tests are semi-structured or unstructured and use ambiguous stimuli ranging from less ambiguous such as pictures, incomplete sentence stems, to ambiguous stimuli such as ink blots. Some of the semi-structured projective tests are Rosenzweig picture frustration test, thematic apperception test, Rotter's incomplete sentence blank, and unstructured projective tests are inkblot tests, such as Rorschach inkblot test. Since these tests do not rely on explicit verbal questions, so the person's responses are not limited to the true, false, or cannot say variety. The projective techniques assume that individuals project their own problems, motives, and wishes onto the test material when they try to make sense out of vague and unstructured stimuli. People reveal their personal preoccupations, conflicts, motives, coping techniques, and other personality characteristics through their interpretations of the ambiguous materials. Projective personality tests have their own advantages and limitations. Though the test stimuli are standardized, however, interpretation of the item. 40. Introduction to psychological disorders and disorders of anxiety and obsessions. Responses is subjective and unreliable. Projective tests are especially useful in clinical settings to obtain a comprehensive picture of a person's psychodynamic functioning. However, its strength is its weakness also, as their interpretation is subjective, unreliable, and these are not time and cost-effective in terms of administration and interpretation. Observing behavior. Behavioral observation involves observation of symptoms and problems related to psychological disorders. C. Behavioral and cognitive assessment. Behavioral and cognitive-oriented clinicians are guided by the system that leads them to assess four sets of variables. Sork, Canfer and Phillips, 1970, S equals stimuli, the environmental situations that precede the problem. The clinician may try to identify the stressors that tend to elicit a given maladaptive behavior. O equals organismic, referring to both physiological and psychological factors assumed to be operating under the skin. Perhaps, the client's fatigue is caused in part by excessive use of alcohol or by a cognitive tendency towards self-deprecation manifested in such statements. I never do anything right, so what is the point trying? R equals overt responses. Clinicians determine what behavior is problematic, as well as the behavior's frequency, intensity, and form, e.g., a client might say that she is not assertive. Does the person mean that she is not assertive in all situations and with everybody, or it's specific to situations and people? C equals consequent variables, events that appear to be reinforcing or punishing the behavior in question, e.g., when the client does not show assertiveness, it pays by maintaining the status quo, thereby keeping the person from being assertive. A behaviorally oriented clinician attempts to specify Sork factors for a particular client. Followers of Skinner underplay the O variables and focus more on S, R, and C. Cognitively oriented behavior therapists pay less attention to C variables because cognitive behavior paradigm does not emphasize reinforcement. The information about Sork is gathered by several methods such as direct observation of behavior in real life as well as in contrived settings, interviews, and self-report measures. Bellick and Herson, 1998. 1.8 The integration of assessment data. Integration of the assessment data into a coherent working model that helps in diagnosis, prognosis, and treatment plan. Assessment data is integrated either by the clinician or an interdisciplinary team of professionals, such as psychologist, psychiatrist, neurologist, psychiatric social worker, nurse, and physiotherapist, and occupational therapists, etc. It also helps in evaluating the outcome of therapy and in comparing the effectiveness of different therapeutic and preventive approaches. Butcher et al. 2017. 41. What is a psychological disorder? 1.9 Ethical issues in assessment. According to Butcher et al. 2017, clinical assessment of an individual has far-reaching implications for him, her. For example, a clinical interpretation may implicate a person as a patient in need of treatment or as a criminal to be punished. Since it may affect a person's personal as well as professional life, so sources of biases should be kept in mind while making a clinical assessment of a person, such as a potential cultural bias of the instrument, b. cultural bias or theoretical orientation of the clinician, c. inadequate emphasis on the external factors, d. insufficient validation of information about the client or his/her situation, and e. insufficient data or premature evaluation. By considering the strengths and weaknesses inherent in the procedure of clinical assessment, a clinician or a team of mental health professionals can efficiently use it to diagnose and treat the clients. 1.10 Summary. Now that we have come to the end of this unit, let us list all the major points that we have already learned. Psychological disorder is a psychological dysfunction within an individual that is associated with distress or impairment in functioning and a response that is not typical or culturally expected. The earliest evidence about attempts to understand abnormal behavior comes from 16th century BC from Egyptian papyri. Humanitarian treatment of mentally ill patients began in France by Philippe Pinel. 42. Introduction to psychological disorders and disorders of anxiety and obsessions. Ancient Indian texts, like Atharveda, Ayurveda, Charaka Samhita and Sushruta Samhita have discussed about diseases that include mental disorders also. Classification can be defined as making generalizations based on our observations. Classification is a necessary step for making sense of information in all formal fields of knowledge. Classification differentiates among various types or categories of maladaptive behavior and brings order to the nature, causes, and treatment of such behavior. The DSM-5 was published in 2013 and has used an operational approach to diagnosis. Necessary, sufficient, and contributory causes are required to classify abnormalities. Psychological assessment refers to a procedure by which clinicians, using psychological tests, observation, and interviews, develop a summary of the client's symptoms and problems. There are three types of assessment: biological assessment, psychological assessment, and cognitive and behavioral assessment. 1.11 Keyword Psychological dysfunction refers to breakdown in cognitive, emotional, or behavioral functioning. Distal causal factors. Causal factors that occur early in life and may not show their effect for many years, but may contribute to a predisposition to develop a disorder. Diathesis stress model. The diathesis stress model is a psychological theory that explains behavior as both a result of biological and genetic factors, nature, and life experiences, nurture. Brain imagery. Seeing the brain and how its structure and functioning may be related to abnormal behavior. Neurochemical assessment. Analyzing the metabolites of neurotransmitters that have been broken down by enzymes. Neuropsychological assessment. Assessing behavioral disturbances caused by brain dysfunction. Psychological tests. Standardized sets of procedures or tasks for obtaining samples of behavior. Reliability refers to consistency of measurement. Validity refers to whether the measure fulfills its intended purpose.